Hello, everyone. Thank you so much for joining us today at this um, town hall session for about the COVID-19 vaccine. And uh, my name is Meher Graywalt, and just to tell you a little bit about myself, I will share my screen. Please let me know if you can see this. Can you see this?
Yes.
चालेल आलं हो थँक्यू राजेश थँक्यू बेटा
Yeah, so just to tell you a little bit about myself, my name is Meher Graywalt, and I'm an 8th grader in Bellevue, Washington, at Odell Middle School in Bellevue. And I am the volunteer junior program manager of the school microbiome program for life at the DePaolo lab with UW Medicine. And I'm also very passionate about community outreach and making a positive impact. So this this event is hosted by Worth a Shot, and Worth a Shot is a community effort to raise awareness about the COVID vaccine, answer questions, and help build herd immunity as the COVID vaccine gets rolled out to the wider public. So here's a little bit about Worth a Shot. So many people in the community have fears, questions, and concerns since this mRNA technology is very new technology. So it's very normal that people would have those questions. But we're trying to provide answers to the most commonly asked questions as the vaccine gets distributed to the wider public. And right here, you can visit our website. I know that the full link didn't show up, but is on our website, www.youthAwareMagazine.com. And if you look under the Community Initiatives tab, you can see the Worth a Shot page, which has all of this information right here. And our mission is to, I went over our mission already, and we are, along with our community partners, we're distributing resources in multiple languages, presenting at schools and community centers, and we've also spoken to experts on the COVID vaccine. And all this information, I'll go into detail in further slides, but all this information is available on our website if you would like to check it out. These are some of our community partners. We want to take some time to acknowledge all our community partners for supporting us in this effort. And over here, these are some of the resources that are on our website. And this is our vaccine, a little booklet that we've created on the vaccine with answers to the most commonly asked questions that the community has. So this has answers to frequently asked questions such as about the mRNA technology and about when people can expect to have the vaccine available to them. And as I mentioned before, these are our language translations. So we have translations in multiple languages for people that don't have English as a first language. So you can definitely check that out as well. So today we're very honored to have some speakers with us tonight who will be talking to us about the COVID vaccine. And these are our speakers that will be giving us different perspectives from their lines of work. And first we have Dr. Lukena Karkhanis, and we're very honored to have her here today. Here's a little bit about her. So she's a diplomat with the American Board of Allergy and Immunology, and she practices at the Allergy, Asthma, and Immunology Associates of South Texas. So you will hear from her very soon. We have Dr. Malhotra, and we're so excited to have her here with us today. She's an infectious disease specialist at Virginia Mason Hospital. And then we also have Dr. Prachi Munshi. We're so grateful that she could join us today as well. She's from the Polyclinic, and you will hear from her as well. So this is an opportunity for you to have your questions answered about the COVID vaccine. And if you have any questions, feel free to ask. So we'll have a short Q&A after all our speakers have presented. So after all the speakers have gone, you will have the opportunity to ask ask them questions, and we also gathered questions from the community for people that couldn't make it here today. So I'll stop sharing my screen now. And yeah, thank you so much to everyone for joining us here today. And now I'm going to hand it over to Shravya, who will introduce our first speaker.
Yeah, so hi, I'm Shravya, and today we're honored to have Dr. Lukena Karkhanis here with us today as a speaker. Dr. Karkhanis is a diplomat, and she received her qualifications from the American Board of Allergy and Immunology. She practices at Allergy, Asthma, and Immunology Associates of South Texas. Dr. Karkhanis completed her internship and medical residency in internal medicine at St. Luke's Roosevelt Hospital Center and in Columbia University, New York. And later on, she completed her fellowship in allergy and immunology from Washington University School of Medicine and also in the Barnes Jewish Hospital in Missouri. So right now she serves as a sub-investigator on several studies at the Allergy and Asthma Research Center. Dr. Karkhanis has also been an active peer educator and has done several educational webinars for many physicians. So thank you so much for joining us, Dr. Karkhanis.
Let me share my screen. Thank you very much to Mayor and the Worth a Shot community for giving me this opportunity to talk to all of you. Are you able to see my screen?
Yes.
Okay, so let's start. So I'm going to talk briefly about COVID-19 and the current mRNA vaccines that we have, and hopefully it won't take too long. So the COVID-19 pandemic, which is also known as the coronavirus pandemic, is an ongoing pandemic of COVID-19 disease caused by the virus called severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2. So the name of the virus is SARS-CoV-2 and the disease is COVID-19. It was first identified in December 2019 in Wuhan, China. And the World Health Organization declared the outbreak as a pandemic in March 2020. So it's been almost a year that we are living with a pandemic. And as of January 18, 2021, more than 110 million cases have been confirmed worldwide, and 2.45 million deaths worldwide attributed to COVID-19. So this pandemic has caused global social and economic disruption, including the biggest global recession since the Great Depression after World War II. A very quick review about the virus. So SARS-CoV-2 virus, it comes from the family called Coronaviridae or coronaviruses. These viruses typically have an envelope around them, and their genetic material is stored as a single strand of RNA. So these viruses have RNA in them. Not very big in size. They're about 30,000 bases in length, their genetic material. And the virion or the viral particle is about 50 to 200 nanometers in diameter. And to give you a rough estimate, 1 millimeter is about 1 million nanometers. So very, very small viruses. They have several proteins, but the four main ones are the spike protein, which is of interest to us because that's what the vaccine has targeted. And in this picture, it's shown as these big red triangles projecting from the virus. The envelope protein, that's the gray part here. The membrane proteins, which are these smaller particles depicted here. And then you have inside the envelope, the nucleocapsid protein, which actually stores the virus's genetic material. And this virus uses various receptors in our body to enter our cells, for example, ACE2 receptors and passaging. So let's quickly review a little bit of our high school human cell biology. What does a typical human cell look like? So we are all made of millions of cells. Each cell is like a blob of a different size and shape. It typically has a membrane around it, like an envelope of its own called the cell membrane. And inside the cell is a smaller area called the nucleus, which is where our genetic material, our DNA lives. It lives inside the nucleus and it's bound by its own envelope or nuclear membrane. So this is a very secure part of our cell. And it's important to remember this because keep in mind, the RNA viruses like SARS-CoV-2 and the mRNA vaccines cannot enter this nucleus. So our genetic material is kept very securely inside our nucleus. It's surrounded by various proteins and it's tucked away safely. It's very hard for anything outside to enter our nucleus. It's kind of like, compare it to the safe in your house, you know, any random thing that enters your house cannot really enter your safe because you need to know where the safe is and you need to know the combination to the safe and so on and so forth. So similarly, our nucleus is like a safe for our DNA. And then outside the nucleus, you have other parts of the cell that are essential to the function of the cell. So you have what's called the cytoplasm, and then you have various structures that work to make proteins, including Golgi apparatus and endoplasmic reticulum, and then structures that are essential for the cell to live, like the mitochondria. So what happens in our cells? We have DNA. DNA is how our genetic code is stored, and this DNA gets converted to what's called RNA, messenger RNA, that's mRNA. This happens in the nucleus. So when our cells decide that a certain part of our genetic code needs to be translated, our DNA, which is typically double, opens up, and some part of it undergoes a process called transcription and makes this RNA, mRNA. This mRNA then leaves the nucleus and comes outside, and then it finds a special structure called the ribosome. The ribosome then translates this mRNA into a protein. So think of your DNA as the blueprint, okay? So the blueprint for your house, which is made. The mRNA is kind of like the standard operating procedure. So the contractor has to look at the blueprint and then he has to make the actual construction plan. So the mRNA is like the message in that construction plan. And then the protein is the actual construction, the walls and the ceiling that get constructed. So this is how the blueprint gets converted into the actual construction, is by going through mRNA and then going through the ribosome and having a protein formed. Now it's important to remember that this is what our cells do. This is how we are made, right? Our bones and organs and blood and skin and enzymes and hormones, everything is made from DNA to mRNA to protein. So this is not a new process for any of our cells. This is what our cells do. From birth to death, they take DNA and they make mRNA, and they take mRNA and they make protein. So though the mRNA vaccines are new, it's nothing new to our body. Our body has basically been converting mRNA to protein all this time. So it's not a new process for our cells. Let's quickly look at how does this COVID-19 virus, this SARS-CoV-2 virus, infect our cells. So this looks like a complicated picture, but I'll simplify it, okay? So let's assume that this is that viral particle. It has its RNA, its genetic code inside, it has an envelope, and then it has these spikes, the spike protein. So when it enters our body, it kind of floats along our cells until the spike protein is able to attach itself to a receptor on our cells. That is what allows this virus particle to then enter that human cell. Once it enters that human cell, it releases all its proteins and its RNA, and it then basically hijacks our protein making machinery, that mRNA ribosome protein making machinery that all our cells have. The virus hijacks it and starts using it to make its own protein. So instead of making cellular proteins, that cell starts making virus proteins. It makes nucleocapsid and spike and membrane, and it makes more RNA because this is a live virus we're talking about. Those then assemble into new viral particles, which get released from that cell. They go and infect the neighboring cell, and then the neighboring cell, and so on and so forth. So this is how viruses typically invade our body, invade our cells, multiply by hijacking our protein making machinery, and go on replicating. What are vaccines? So a vaccine is any biological preparation that provides active acquired immunity to a particular infectious disease. And typically vaccines contain an agent that resembles that disease-causing organism that we are trying to fight. It's often made from a weakened or killed form of the microorganism, or one of its toxins, or one of its surface proteins. So this is the basis of the field of vaccine development. And this agent in the vaccine, its purpose is to stimulate our body's immune system to recognize it as a threat and to try and destroy it, and then to remember and recognize and destroy any similar microorganisms that it may encounter in the future. So it's almost like training the soldiers of your immune system. It's like a military training exercise. You're teaching them how to fight an enemy and then telling them to remember. So if they encounter the same enemy again, they will remember what they learned in that exercise and they will be much better at fighting it. And vaccination is the most effective method of preventing infectious disease. So nothing else prevents infectious disease as well as vaccination in human history. And widespread immunity due to vaccination is what is responsible for the worldwide eradication of a disease like smallpox and restriction of other diseases like polio, measles, and tetanus from much of the world. Licensed vaccines are currently available for about 29 different human infections, and coronavirus 19 is the latest one. There are others available for animals. So our pets, our dogs and cats also get vaccines, but there are about 29 different human diseases. What are different types of vaccines? So if we take a look, you can have that DNA or that RNA in your vaccine, and that is the one we are going to talk about today, the mRNA vaccine. You can have a live attenuated vaccine. So for example, your oral polio vaccine or your MMR vaccine, the actual virus is live in the vaccine, but a very weak form that can be used as a vaccine. You can have an inactivated vaccine. So you can kill the microorganism and inject killed microorganisms. For example, our injectable flu vaccine is an inactivated vaccine. You can have a subunit, so just a part of the microorganism. For example, our hepatitis B vaccine is a subunit vaccine. Tetanus vaccine is a subunit vaccine. Or you can have a viral vector vaccine. So you can take a different, safe, non-infectious virus and insert your microorganisms genes inside it and use. And this is the AstraZeneca vaccine that's currently being used in other parts of the world like India, not in the US yet, but those are viral vector vaccines. So we are going to talk mainly about the mRNA vaccines that are available in the United States right now. So how do these mRNA vaccines work? So you have the Pfizer-BioNTech vaccine. It has a very fancy name that nobody really uses, tocilizumab. And then you have the Moderna vaccine, and it's called mRNA 1273. So these are the two mRNA vaccines for COVID-19 available in the US currently. So imagine that this is the vaccine particle, okay? It has a lipid envelope. So it has a oily envelope that is necessary to keep that mRNA stable and to deliver it to our cells. Inside that envelope, the scientists have put the mRNA, so the standard operating procedure or the construction plans on how to make the spike protein of this COVID-19 virus, this SARS-CoV-2 virus. So that's what they've put inside, a message or a construction plan on how to make the spike protein specifically. Once this vaccine is injected, it goes into the muscle cells and it releases this mRNA. And like we know, our cells are continuously taking mRNA and converting it into protein. So when they see this little bit of foreign mRNA, they just pick it up and put it on their ribosome and they start making protein, and they end up making the spike protein of the COVID-19 virus, the SARS-CoV-2. And then they don't know what to do with it because it's not a protein that's necessary for the cell's survival. So they either chew up the protein into tiny little bits because they think this is a foreign entity. And then those bits get loaded onto specific receptors on the cell surface, because the cell is hoping that a neighboring cell, an immune cell, will come by and recognize and figure out what to do with it. Or they release the spike protein in outside the cell, or they display it on its surface, hoping that again, some neighboring cell, some immune cell will figure out what to do with it. So this is how the mRNA inside the vaccine gets formed into spike protein and bits of spike protein. As you can see, this does not go anywhere near our nucleus. So it cannot interact with our DNA, and it cannot insert COVID-19 genetic material into our genetic material. So what happens when the spike protein is made? What does the spike protein then do? So any vaccine, right, once it makes what it's supposed to make in the body, in this case, a spike protein, it is then recognized by a very special cell called an antigen presenting cell. And this cell picks up that information, that spike protein and the bits of spike protein, and it basically passes it on to the soldiers of our immune system. These are very special types of our white blood cells. They're called lymphocytes, and there are two main types, T as in tiger lymphocytes and B as in boy lymphocytes, T lymphocytes and B lymphocytes. And these are the soldiers. So the antigen presenting cells take that spike protein and show it to these soldiers. And then these soldiers then go on to mount a response. They recognize that this is a foreign protein, it's a danger signal, the cell that made it is infected, and they try and destroy it, and they try and mount a response to that spike protein. The B cells do it by making very special proteins called antibodies, and the T cells do it by becoming very specialized cells called cytotoxic T cells and helper T cells. And these antibodies and specialized T cells go on to destroy the spike protein and the infected cells in our body. What also happens is some of the B cells and T cells turn into memory cells. So our immune system is smart enough to recognize that it needs to remember what it's learning in the training exercise. So these memory cells will then last for a very, very long time. So when our body gets exposed to actual coronavirus infection, these memory cells will already be ready to fight it. They will remember exactly what antibody to make, what protein to destroy, and we won't be starting from square one. So that is how we develop immunity, and we develop immune memory to the spike protein. So the mRNA vaccines in US, right? In December 2020, the United States FDA granted emergency use authorization to the Pfizer and Moderna vaccines. And it's called emergency use authorization because the FDA will not grant full approval until they have more data. But they do recognize that these vaccines are safe and effective, and they are very, very necessary given the level of the pandemic we are in. So they have given emergency use authorization. These are both mRNA vaccines. They do not have any live virus in them. They are enclosed in that lipid nanoparticle, like a fatty layer, like we talked about. These vaccines are preservative free. There's no formaldehyde, there's no mercury, there's no thimerosal, there's no antibiotics, there's no latex, no gelatin, no dairy, soy protein. There's really nothing in those vaccines. They are very, very clean vaccines. And this mRNA, like we talked, is a message. It shows our cells how to make that SARS-CoV-2 spike protein. And then that spike protein initiates the immune response and trains our body to recognize and fight COVID-19. And this mRNA never enters the nucleus of the cell, so it doesn't affect or interact with our DNA at all. And to date, about 58 million doses of these mRNA vaccines have been administered in the United States alone. Now, a lot of people are concerned about the fact that this is emergency use authorization and these vaccines were developed warp speed or very quickly, and maybe something was overlooked. So keep in mind, what was speeded up was the red tape and the paperwork that usually surrounds any new approval. So basically, vaccine research, like any research, is very expensive. and scientists have to go around looking for funds, looking for companies to invest in them. This time, recognizing the need that we are facing, this research was funded by the governments, okay? So they didn't have to worry about looking for money. They were given all the permissions they needed. Otherwise, typically it takes them months or years to hear back from the FDA. So that was speeded up. The data was analyzed as it was made available. And lastly, given how much coronavirus disease we are having, these scientists could recruit volunteers very, very quickly. So 30, 40, 50,000 volunteers in the 2 trials alone were recruited in a question of days or weeks. Normally, it takes us years to recruit even 100 volunteers for a trial. So to get these tens of thousands of healthy people like you and me to volunteer to be in a vaccine trial, that is what really speeded up the research. Nothing else was overlooked. The data was scrutinized just as deeply, and everything was done with just as much due diligence as before. So none of the scientific or medical aspects were speeded up or overlooked. So let's look at the common side effects, because a lot of people are worried about side effects from these COVID-19 vaccines. So if you look at Pfizer and Moderna, the common side effects or adverse reactions were really common ones that we see with any vaccine, okay? So injection site reaction like swelling or redness, fatigue, tiredness, headache, muscle pains, chills, joint pain, feverish feeling. These were the common side effects. And these are kind of expected because keep in mind, you're taking a vaccine, you're trying to trigger your body, your immune system to go into a temporary kind of overdrive and start becoming activated. So you are going to have some side effects in some people. There is no medication in this world that has 0 side effects. If anything has an effect, it will have some side effect, okay? So these side effects are minimal. They are temporary. They go away on their own. They are not going to hurt us. And these were the common ones. So really, these are pretty well tolerated vaccines. Lymphadenopathy has been reported. So lymphadenopathy is the medical term for lymph node swelling. Lymph nodes are tiny little factories for immune cells that exist throughout our body. And as you can imagine, when you trigger production in the immune system, the factories get activated. So these lymph nodes can get a little swollen. So the arm in which people take the vaccine, they may feel like they develop swelling in the underarm on that side because that's where the lymph nodes live, or above the shoulder on that side because that's where some other lymph nodes live. And that again is expected. You are triggering these factories to start producing an immune response. So a little bit of swelling is not unexpected. And all of this is again temporary. It goes away on its own. There were some cases of a condition called Bell's palsy reported in the vaccine trials. Bell's palsy is a condition that affects the nerves of the face and causes a temporary, usually mild, almost paralysis of the facial nerve. But again, the number of cases reported in the trials were nothing higher than the cases we see in the general population before coronavirus, before the vaccine. So as of now, we don't think the vaccines are triggering these cases per se. There was possibly some shoulder injury. So that is why you get the vaccine injected from a trained medical professional. They need to know exactly where to give it in the arm. There were some cases of intractable nausea. People that had facial swelling, there were a few people that had a cosmetic procedure called dermal fillers. Dermal fillers are injections that are often given for wrinkles and anti-aging cosmetic procedures. And these often develop swelling at the site where they're injected, even with viral infections. So not unexpected with a vaccine, there was some swelling. Again, it was temporary. And there was no anaphylaxis noted, interestingly, in the trials. Not in Pfizer, not in Moderna. But we have heard, a lot of people have heard and are concerned. So the VAERS system, which is the United States Vaccine Adverse Event Reporting System, After about 2 million doses of the Pfizer vaccine being given out, they had about 21 cases of a severe allergic reaction. And after 4 million doses of Moderna, about 10 cases of severe allergic reaction. So again, very, very rare. So though this has got a lot of publicity, keep in mind, these are very rare. The majority of people are getting these vaccines and maybe getting a mild side effect, but otherwise they are doing very well. What about these vaccines in pregnancy and breastfeeding women? So during the trials, pregnant women were excluded from entering the trial. They were tested every time. And that is because we are usually very, very careful doing trials in pregnant women and babies. However, in spite of all precautions, several women in both trials ended up becoming accidentally pregnant. So 23 pregnancies in the Pfizer trial, 13 pregnancies in the Moderna trial. And these trials typically have a vaccine arm, so volunteers who got actual vaccine, and a placebo arm, meaning volunteers that got nothing. And volunteers in both arms accidentally became pregnant. And to date, all the vaccine arm pregnancies, so volunteers that got vaccine and became pregnant accidentally, unintentionally, they are all doing okay. It doesn't look like this vaccine does any harm to pregnant women. In fact, it helps pregnant women because it prevents coronavirus infection. So these vaccines, the Pfizer and Moderna vaccines, prevent symptomatic coronavirus infection, even mild infection, definitely moderate and severe, but even mild coronavirus infection is prevented. 94 to 95% efficacy. So very, very effective. And it's similar efficacy in pregnant and breastfeeding women. And we know that COVID-19 infection is very bad in pregnancy. Women often end up in the ICU. They have a lot of preterm labor. A lot of babies are born premature and end up in the NICU themselves. So currently in the United States, we recommend that pregnant and breastfeeding women who want to get the COVID-19 vaccine should get the COVID-19 vaccine. It seems to be very, very safe. It actually probably helps mom and helps baby by helping mom, and it doesn't seem to be baby at all. We also do not recommend that women who are breastfeeding stop breastfeeding after the vaccine. Please continue just as you are doing, because there is no biological way, no biological plausibility that the vaccine will cause harm. The mRNA in these vaccines is very, very fragile. So it will disintegrate within minutes to hours. It's not going to reach the breast milk even. And it's not going to reach the breastfeeding baby, and it's not going to harm the breastfeeding baby. In fact, in pregnancy and breastfeeding women, moms who mount an immune response to the vaccine may pass on some of their immunity to their babies, and it may actually protect the baby. So the vaccine may actually help the baby. These are some of the common questions I have encountered. And so I thought I would kind of address them here. But of course, if there are more questions, we are happy to answer them during the Q&A session. So if I've had COVID-19 infection, should I get the vaccine? Yes, you should. It is safe. It is likely efficacious in people with a prior COVID-19 infection. And so we offer the vaccine to everybody, regardless of their history of infection or not. And we do not recommend that people be tested to see if they had infection previously before offering them the vaccine. There is no need to test people before offering them the vaccine. If I have had COVID-19, when should I get the vaccine? So once you have recovered enough to be out of quarantine and you're no longer isolated, you can get the vaccine. There is no need to wait after recovery, but if you wish to wait, either due to some personal reason or a vaccine dose is not yet available to you, you ideally should not wait more than 90 days, because beyond the 90-day period, we do not think natural infection reliably protects you from reinfection. So if you absolutely wanted to wait, don't wait more than 90 days. If you did not want to wait and it is your turn and there is a dose available to you, You can get the vaccine once you're out of isolation. Should immunocompromised patients take the vaccine? So the immunocompromised patients are people with a low immune system, either because they have a deficiency in their immune system, like a genetic defect, or because they are on medications which lower their immune system. So should they take the vaccine? Yes, once they are stable, meaning they are not acutely infected, they are not starting a new medication. If they are stable in their immunocompromised state, they should absolutely take this vaccine. It is not a live vaccine. There is no live virus. It is not going to cause coronavirus infection. And these people that have a low immune system, if they catch COVID-19 infection, they are at a very high risk for serious complications. So they need every little bit of protection that they can get. They may not mount as good a response as a healthy individual, but every little bit helps. So they should absolutely take the vaccine. A lot of practices, including my practice, are still waiting to get our shipment. There is a lot of concern because of some false claims online that the vaccine will sterilize you. It will keep you from having babies in the future. And this is absolutely not true. There is no biological plausibility. There is no biological way in which this vaccine would do anything to your fertility or your ability to have babies. Keep in mind, if you don't take the vaccine, right, in trials, they compare vaccine to placebo. But in real life, you and me, we are deciding between how do we fight coronavirus? Do we fight it with vaccine protection or we fight it unprotected? We don't have the luxury of staying in a bubble our entire lives. And COVID-19 infection is spread so much worldwide that eventually each and every one of us is going to be exposed and we are going to have to fight it. So how do you want to fight it, with protection or unprotected? That's our choice, right? And if we are worried about some false claims for things that are not even true, then what do you think will happen when you actually catch COVID-19 infection? You're going to produce the same spike proteins, only 100 million times more. And you're going to produce all the other proteins that will harm your body. And if you worry that the vaccine will keep you from having babies in the future, then you should worry that the infection is going to be far, far worse. So there is, again, no need to worry about sterilization with the vaccine. What about mutations? So recently we've heard about mutations and new variants. So these are coronavirus that are slightly different in their genetic code. And everybody is wondering if the vaccine will work, right? So luckily for us, SARS-CoV-2 does not mutate in large amounts like the influenza virus. So the flu vaccine, we have to take a booster dose every year because every year there is a very different strain that comes up. And fortunately, the coronavirus is not able to mutate that way. The spike protein, which is our vaccine target, is conserved across all strains so far because it seems to be essential for the virus's survival. So it's highly unlikely that we will encounter a coronavirus that does not have the spike protein at all, because that virus will probably not be able to survive or infect us. And so far, the vaccines are working against all the current strains. The efficacy may be different, but they are working. It's not a 0% efficacy. These variants, right, keep in mind, the spike protein is about 1,700 amino acids big, and these mutations are about 8 to 10 amino acids. So it's like, you know, a Christmas tree. Everybody's Christmas tree is decorated differently and it looks different, but you can still tell that it's a Christmas tree. Similarly, even though these mutations change the spike proteins here and there, our body, our immune system will still be able to recognize that it is the coronavirus spike protein. Will we need annual shots like the flu shot? We don't know so far. However, it seems unlikely because reinfection rates are still very low. And even before the vaccine, they were very low. We need to wait and see what happens. How long does this vaccine immunity last? So we don't know for sure. We know now that it lasts several months. In immunology, we know that vaccine protection typically lasts several years. Our bodies seem to have pretty good immune memory, but we don't have a good way to measure this and prove it yet for SARS-CoV-2. So we don't have a good way to measure the immunity. We can check for antibodies, but these are the B cells we talked about. The T cells we talked about, we don't even have a good test to measure them. So we will have to wait for decrease in new infections and hospitalizations and death and reinfection, wait for our community spread levels to go down. And that's how we are going to know how long our immunity lasts. There are some concerns if the vaccine is making the spike protein, and will that cause our cells to attack those cells and develop autoimmunity? So you have to keep in mind that our immune cells get trained in a very special organ called the thymus while we are still in our mother's womb. Even before we are born, our immune cells get trained to recognize self and foreign antigens, and they remember it for the rest of our life. So it's very, very rare to develop autoimmunity. Yes, some people are unfortunately developing autoimmune disease, but it stays rare. And during natural infection with coronavirus or flu virus or RSV or any of the millions of viruses that are attacking us all the time, our cells very similarly take the DNA, RNA, make protein and display it on the cell surface. So if this process were to be the trigger for autoimmunity, we would not have survived past childhood. So fortunately for us, this does not seem to be the main trigger for autoimmunity. And in my opinion, this risk for autoimmunity is theoretical. There is never going to be a 0% chance in nature, but it stays very, very improbable. Some people are concerned about a phenomenon called antibody-dependent enhancement. So this was seen with a different disease called dengue, where after the vaccine, people who caught the disease actually had a worse course. That has not been seen in SARS-CoV-2, in COVID-19 at all. In fact, people who got the vaccine have consistently done much better with subsequent infection than people who did not get the vaccine. So this is again not a concern so far. Will the vaccine integrate into my DNA? So people are concerned that this is an mRNA vaccine, it's going to go into the DNA and it's going to change us. So this is not possible. The way that our body works, the DNA is in the nucleus, mRNA is formed and is pushed outside into the nucleus. It's a one-way street. mRNA cannot go back into the nucleus. It cannot go anywhere near our genetic material. Now, here we are talking about preventing DNA change, but there are people that have genetic diseases that want DNA change. They're trying for gene therapy. Even when we are trying for it, it is so hard to change our DNA. So in this case, where we are not even trying to do it, where we have taken all precautions to prevent it, it's unlikely that the vaccine is going to go anywhere near our DNA. There is no enzyme needed. The enzyme needed to make RNA into DNA is lacking in the vaccine. So this vaccine is not going to change our DNA. What are the long-term concerns? Because it's a new vaccine, a lot of people have concerns. So keep in mind, like we discussed, this is nothing new for our cells, right? They are constantly turning mRNA into proteins all the time, all our lives, and we are doing fine. Little bit of 0.3 ml, 0.5 ml of new mRNA, our cells probably don't even realize that it's new. They just make it into protein and then they destroy the mRNA right away. So nothing bad is going to happen because our cells are made to do this. They are mRNA translating all their lives. mRNA vaccines are more precise. They are less prone to contamination. Once you have the setup, they're actually easier and cheaper to manufacture. So imagine a friend that has a lot of food allergies and you wanted to bake them a cake. Now, if you were to bake the cake in your kitchen, you would worry about contamination. You would worry, was this bowl used for eggs yesterday? Did I put this spoon in the butter? Can my friend eat wheat flour? And you would worry about the cake you bake. Instead, you could just give the friend the recipe because they have their food allergies. They know best how to cook and their kitchen is probably safe for their cooking. You could give them the recipe. They could make the cake on their own that's best suited for them. And that is so much less prone to contamination. So it's the same with mRNA vaccines. Instead of trying to make the spike protein outside the body in a cell line, right? Because these are proteins, you cannot make them on a 3D printer. You need cellular machinery. If you make them in a cell line, then you are worried about the contamination from that cell line's proteins. Instead, you can just give the message, the mRNA, to your cells, and your cells can then make it as it is best suited to them. And that's why they are less prone to contamination and they are more precise. After getting vaccinated, can we discontinue social distancing measures? So no, we cannot discontinue these. We still have to wear a mask. We have to wash our hands, sanitize, practice social distancing, avoid indoor gatherings with people that we do not live with. This is because vaccination we know it keeps us from getting sick, but there may be others around us who are unvaccinated and the disease may spread to them, especially children, because the vaccine is not yet approved for those less than 16 years of age. There are many people that have chronic conditions like hives and mast cell disorder. What can they do about the vaccine? They should absolutely get the vaccine. Everybody should always stay on all their medications. They should not stop any of their medications on the day of their vaccine without asking their doctor. People that carry EpiPens or epinephrine auto-injectors for other reasons, they can take it with them to their vaccine appointment. Because keep in mind, if you have a chronic health condition, COVID-19 infection will be way worse for you than the vaccine. So overall, the message today is this vaccine is worth a shot. It's going to protect you, and it's likely not going to give you any major side effects. These are my references, and I think we can now continue on to the next presentation and then do questions in the end.
Yeah, thank you so much, Dr. Karkhanis. This was an amazing presentation. It was such an amazing talk, very comprehensive and very informative. And I think one main takeaway, I really loved all of the different analogies you use, especially the one about baking a cake for a friend with food allergies. I think it really helped all of us to understand and grasp the concept better. And we're so honored to have you here today.
Thank you.
So everyone, I would encourage everyone, if you do have any questions for Dr. Karkhanis, please keep those questions in mind, because we will have a Q&A session after Dr. Malhotra's presentation. So just please keep that in mind. So now I will hand it over to her curate.
All right, so now for Dr. Malhotra, we are so excited to have with us Dr. Malhotra, Dr. Uma Malhotra. She is an infectious disease specialist at Virginia Mason Hospital, and she did her residency at the California Pacific Medical Center in San Francisco. She then did her fellowship in infectious diseases at the University of Washington and an immunology fellowship at the Benaroya Research Institute in Seattle. Dr. Malhotra's focus is general infectious diseases, infections in immunocompromised patients, travel medicine, HIV cure, and complex wound management. Thank you so much for joining us, and I would like to give it off to Dr. Malhotra.
Are you able to see my slides?
No, Dr. Malhotra, we can't see your slides.
Okay, let's give it.
Yes, thank you.
Did that work?
Now.
Okay, excellent. So thank you so much for that introduction. And I want to actually congratulate Meher and the team for this amazing forum to share information with our communities. And I'm very happy to be a part of this. And thank you to Dr. Karkhanis for her amazing talk. And I think that makes my work actually really so much easier since she laid out the background very nicely for my portion of the talk. And so I'm going to be focusing on non-vaccine issues pertaining to COVID. So here is my outline. I'll talk about transmission, clinical picture, management, long haulers, and the role for Ayush ministry. And Ayush is the ministry in India that the acronym stands for Ayurveda, Yoga, Unani, Siddha, and Homeopathy. And as we heard earlier from the prior talk, the virus is called SARS-CoV-2. And the disease, it's called COVID-19, although we tend to use the terms alternately. And SARS-CoV-2 is one member of a large family of viruses that are called coronaviruses. And as we learned, these are single-stranded viruses, and there is a fringe, with the spike proteins, and that's how the viruses get their name, coronaviruses, and corona stands for crown. And most of these viruses in this family actually infect animals. So there are only 7 viruses here that infect humans in this family. And 3 of these 7 viruses have actually caused, very severe illnesses, whereas the other 4 cause common cold. And the 3 viruses that have caused severe illnesses is the SARS-CoV that occurred about a couple decades ago, and then occurred MERS infection about a decade ago, and now we are dealing with the SARS-CoV-2, which is the 7th coronavirus to infect humans. And coronaviruses are actually widely distributed in bats. And bats they're very important creatures, very helpful to pollination and agriculture, but they also carry large numbers of viruses. And humans can get some of these viruses either from direct contact with bats, or they can get them, through contact with what we call an intermediate host, via a spillover dynamic. So, we talked about SARS-CoV that occurred, the first SARS infection in 2002. And there, civets in wet markets, meat markets, were thought to be the intermediate host, whereby the virus passed from bats onto civets and then onto humans. And then MERS was, via camels. And that's, primarily the outbreaks occurred in the Mideast. And the most recent outbreak is thought to be, via pangolins, which are, one of the most trafficked animal on Earth, really prized for what are thought to be, its medicinal properties. And so understanding human-to-human transmission is clearly, crucial to controlling this pandemic. And over the last year, we have learned a lot about this. And we have learned that transmission is a combination of droplet and airborne. So droplet is usually, when somebody sneezes at you, and you can almost, see the little droplets, and you breathe some of those large droplets. But airborne is, when you're in a closed room or you enter an elevator, the person is gone, but there could still be virus, hanging in the air. And another thing that we learned, which is making this pandemic particularly challenging, is that people become infectious even before they become ill. So, so a person may look perfectly fine, but they could still be transmitting to other people. And as we will, I'll go over that patients with COVID can have a variety of symptoms, from being having no symptoms at all, to having few symptoms, to many symptoms. And we have learned that all of these types of patients can transmit virus to others. So this is an example that occurred not far from us in the Skagit Valley, close to Seattle. And this was a choir, and this occurred early in March, where we were still learning more about the pandemic. And here people decided to gather for this performance. And at that time, there were no, huge restrictions on gatherings. And these people made sure that no one was feeling sick or ill, nobody was coughing. And there were about 60 members of this choir that gathered. And at the end of it, 75% of them came down with the illness. And 2 people died. And it is suspected that there was, airborne transmission, just nobody coughing or sneezing, but just we are breathing. They were sending viruses around, which other people were breathing. So here we learn that it's not just, safe enough to say, oh, I feel okay, so I'm going to gather with 10 other people who also feel okay. It's because we know that people may be feeling quite well, but they could still be transmitting virus, because either they could be asymptomatic transmitters, or what we call pre-symptomatic, that is before they actually become ill. And that's the time that people could be actually highly infectious. So here was a mathematical model that shows us that what the contribution of individual modalities of transmission could be. And so this light blue, about almost half of the transmission appears to occur from people who haven't yet become ill. So the pre-symptomatic, before they develop symptoms. And another about 40% appears to be from people who are symptomatic, having a fever, cold, cough. And another about 10% or 5% appears to be from touching surfaces that may be contaminated by other folks. And then an even smaller percentage appears to be from people who may never develop symptoms, because it is now thought that these people may carry just small amount of virus. And let's look at the trends over the prior year. And clearly the pandemic has hit the US pretty hard. And as we can see, we have had multiple peaks, first peak, second peak, and this third and fourth waves. And here, we got up to rates of about 250,000 infections each day. And fortunately, we are on a nice, downward trend here, but still we are, getting about 60, 70,000 infections a day. So let's see what happened to India. And so India is in this blue line here, and India has had only one peak, which has been very fortunate for that country. And there's just a lot of speculation among scientists why India has done, so well, to see what we could learn from how the country has managed the pandemic. And so India peaked in about late fall with almost 100,000 cases a year, 100,000 cases a day. And more recently, it's been down to about 10,000 cases a day, although there has been a little uptick to about 11 or 12,000 cases a day. So here is just a little kind of closer look. So we peaked at about almost 100,000 cases a day, and now down to about 10 to 12,000 cases a day. And one reason, one speculation is that a big part could be the huge emphasis that the Indian government paid on masking, distribution of free masks, and imposing fines for people who were unmasked. So not only people were fined, but they were at the same time handed a free mask. So that message, really got around, and is likely, one major component for why India has done so well. And I think there are many other components there as well. And so let's look at what's happening in Washington State. Again, daily cases. And so we've had, one wave, second wave, and this most recent wave was uh, quite severe. And we are fortunately, again, on a downtrend. And so just to explain a little bit about what happens when we talk about opening and closing our counties and states. So we hear that from our governor that it's time to, close, time to open up. And so it really is following the trend in the pandemic. So as soon as, so orange here is that there is restriction, and green is that the counties and state is opening up. And so when you start to see an increase, that'll be associated with closing of the counties. And when there is a downtrend, it'll be associated with opening of businesses and restaurants, etc. Again, so the government is very closely monitoring what's happening to the severity of the outbreak as it makes decision about opening, closing of businesses and schools. And what about COVID symptoms? So it's important to know that about 80% of the cases are actually very mild cases. And these patients may have, some fever, cough, headache, body ache, sore throat. But then about 20% of the cases, or 1 in 5, becomes more severe. And with about 1 in 20 cases actually requiring admission to an intensive care unit with respiratory failure, requiring mechanical ventilators, etc. And other symptoms to be aware of besides the usual, respiratory symptoms like fever, cough, sore throat. Patients may have what we call flu-like symptoms, such as just, chills, body aches, headaches, and some people may have just isolated symptoms that are more gastrointestinal with nausea, vomiting, diarrhea. So be aware of that some patients may never have respiratory symptoms. And we have seen some newer symptoms such as loss of taste, loss of smell, and so those are again symptoms to be aware of, and that those could indicate infection with SARS-CoV-2. So what does the illness look like? So the first phase of the illness appears to be driven by the virus itself, the virus replication. And the second phase of the illness appears to be related to the host immune response. And sometimes, especially in the 20% of the patients that we looked at in that pyramid who require hospitalization and intensive care management, it's the immune system that goes into an overdrive, and that is what causes the damage to our body. And these patients, instead of just the kind of the mild symptoms that we looked at earlier, come with severe shortness of breath. They may have shock, heart failure, kidney failure, and what's important to note is that often when I see patients, with these very severe symptoms coming in, they will say, "Oh, I actually got ill a couple of weeks ago, and I thought I was actually, doing better and getting ready to get back to work." And then came the second phase of the illness. So if you or your family members are ill, so really watching, for that second phase of the illness, and it may mean that you need to monitor your oxygenation at home well, so you can catch that phase early and seek medical attention. And when patients come with severe COVID, then as I discussed, they may have failure of their respiration. So we call that ARDS. Their heart may start failing, their kidneys may fail, they may develop strokes, and they may, because of that immune system going into overdrive, they may start developing large blood clots. So these clots can be present in a lot of their large veins, or they may be present in the veins in their lungs. So which again can make their breathing even worse, or they can develop severe strokes because of blood clots to the brain. And what about the laboratory features in patients with COVID? So these patients with COVID, they may have defects in their liver enzymes, their clotting factors, enzymes from their heart, kidney functions. And how do we diagnose COVID? Because the blood tests that we were talking about, these are quite what we say non-specific. So they are not in themselves diagnostic of somebody having COVID. So what we need to do is, do a test that actually looks for the presence of virus. And I'm sure you have heard about nasal swabs. So here is somebody getting a nasal swab, and where the provider sticks a swab up the nose, takes a sample, and that sample is then tested for the presence of virus. And that test can be a molecular test, which means that it's actually looking for the RNA in the virus. Or it could be an antigen test. And the antigen test is actually looking for viral proteins. So that's the difference. And what I'll show here soon is that this is a lot more sensitive assay. And this is not as accurate. So you could miss, a lot of infections if you're doing an antigen test. But often the antigen test is what is more widely available commercially. And the serology test is actually measuring the immune response to the virus. So looking for antibodies. So it's not looking for the virus itself. And to detect the infection, here is a graph that shows when these tests are likely to be useful. So the rapid antigen test, which is a rather kind of inexpensive test, but not very accurate, is positive quite soon after the illness and remains positive for about a week or so. It may start becoming positive a few days before onset of the illness. And the PCR test or the molecular test is highly sensitive, but again, not 100% sensitive. And it may remain actually positive for a long time. But important to remember that patients are really infectious, for the first 10 days or so of the illness. But this virus test can be positive, and early on, it made it kind of hard for a lot of healthcare providers to know when a patient could come out of quarantine. And the more we learned that people could just be holding on to this viral RNA for a long time, but that doesn't mean that they're infectious. And the serology tests are actually not very useful in diagnosing an acute infection or early when patients present with the illness. And as we saw earlier, they're measuring the antibody response, and the antibody response can actually, take a couple of weeks for the body to mount. So looking at the individual tests, so as we saw, the antigen tests are actually looking at the presence of antigen or viral protein. And so these tests are rapid and inexpensive. So they may be used by colleges, etc., to do some rapid screening. But again, important to know that a negative test does not rule out, 100% that an individual does not have an infection. The PCR test, which is looking at the RNA, and it's much more time intensive and requires just a more elaborate setup for testing, more expensive, has a much higher sensitivity, and is the test that's used across majority of the hospitals. And finally, the serology test, that involves getting a blood test and looking at the sample of blood to check for antibodies. And a lot of people, want to know, okay, do I have antibodies? Does that mean that I'm immune? So we don't necessarily recommend this test for the public to know whether they're immune or not, because this antibody test can really cross-react with antibodies that may be mounted after exposure to the cold coronaviruses that cause cold. So it could give a false sense of protection. And also, again, the test is not 100% accurate. So with issues around false positives and false negatives, I really don't encourage providers or patients to do this test. I think the main role for this test is probably for epidemiologic purposes and public health purposes, to get a rough sense of how much infection there is in a community. Are there 10% or 20% of the people infected? And so early on in the pandemic, we heard mostly about nasopharyngeal swabs. As you can tell, it's kind of, the swab is really going back, and that's where the virus tends to replicate. But this is also, doing this type of a test is also hazardous for the providers who are taking the sample, because somebody who's being tested, it could trigger a sneeze and throw the virus around. And fortunately, with more and more research, what we have learned is that perhaps it's not, absolutely necessary to send the swab, way back there. And now what we are, or many places are tending to do, is what we call nasal swabs. So the swab is going maybe a half an inch or an inch up the nose. And some of those samples can actually be collected by, so the CDC website has a lot of information, and a lot of those testing kits come with elaborate information on how patients can take the swab themselves. And then, of course, we're also doing more kind of swabs, what we call oropharyngeal swabs, where the swab is taken from the back of the throat via the mouth, and that's not as uncomfortable. So I'm going to switch gears a little here, and I'm going to touch upon how our body fights the virus, and what medicines, drugs, and other therapeutics can be used to make us better and reduce the chance of us dying from the virus. And as you will remember, we talked about that the first phase of this illness is driven by the virus, and the second phase of the illness is driven by hyperactive, or an immune response that is in overdrive. So as would be intuitive, in the first phase of the illness, that is within the first 7 to 10 days, the major emphasis is on antiviral drugs. So drugs that would either depress virus replication or kill the virus, or block the virus, antibodies that may bind the virus, so the virus can no longer bind with our own human receptors. And so those are the major therapies for early in infection. And later in the infection, when patients come to the hospital or they're critically ill, the major emphasis is more on calming that immune system, and suppressing the immune system, so it's not in that overdrive. And we saw a similar depiction in the prior talk. Here is the virus, getting into the host cell, and then it's going to replicate in the host or human cell, and then new viruses are spit out by the host cell. And then here is the immune system, and we have all these immune cells, getting ready to fight the virus. And so as the pandemic broke out, what the pharmaceutical and the drug treatment and NIH and other research platforms started looking at drugs that may inhibit this virus replication. And they started by what we call repurposing drugs. So drugs used it for malaria, chloroquine, drugs used to treat HIV infection, lopinavir, ritonavir, and other drugs. And this also included remdesivir. And remdesivir had been trialed in the prior some of the prior viral infections such as Ebola and MERS. So it was already there and available. So these drugs were brought into trials, and then outside here is drugs to really kind of modulate the immune response. So the drug that got the most attention and has shown the most promise among the antiviral drugs has been remdesivir. And remdesivir was tested in a randomized trial. So, half the people got the drug remdesivir and half got the placebo or saline. And it was found that patients who got the placebo took longer to recover, like 15 days versus 11 days. So it, shortened the duration of the illness. And what about mortality or death from the illness? That it appeared that mortality may be lower in people who get the remdesivir versus those who get the saline. But this effect was not very strong and not very statistically significant. But the improvement appeared to be statistically significant. And so early in the pandemic, this data triggered what we call emergency use authorization of this drug in the use of patients who were admitted with COVID, and ultimately, led to the FDA approval of the drug for use in people with COVID. But here we see that, trials, sometimes can have, depending on the size of the trial and where the trial is conducted and how it's conducted and what the inclusion-exclusion criteria are, the results, can be a bit different. And the World Health Organization, meanwhile, was also doing large trials where they were testing, multiple drugs. And in their trial, they actually did not find that the remdesivir made any difference in mortality in patients with COVID, nor did hydroxychloroquine and chloroquine. And also some of the other drugs that they were testing also did not make a difference in WHO trials. So WHO, or the World Health Organization, does not recommend the use of the drug because it does not think that there is benefit, but the trials in the United States showed benefit in that patients appear to be getting better sooner. So we continue to use the drug in our hospitalized patients when they come within 10 days of symptom onset. But it also tells us that clearly we need, more treatments besides the remdesivir, because remdesivir, people are still, dying in large numbers, the hospitalized people. So we need, additional treatments that would complement the remdesivir and bring reduction in mortality. And this was a large trial that was done through Oxford in the UK. It's called the Recovery Trial. And that trial was a big game changer. So here it shows us, how many people, so when people come on a ventilator, so if 100 people come on a ventilator, 40 of these 100 people are likely to die. So severe illness, of COVID has very high mortality. So 40% people die. And what we found with dexamethasone, and dexamethasone is a steroid, so it dampens the immune response, so that active immune response is dampened, and that allowed 12 extra people to survive. So that's very big. So this has brought dexamethasone in our trials, made it part of routine care across the world. So this is an old medicine. It does not cost very much. But the main thing is that this medicine must be used only in people who are requiring oxygen, because those are the people where the immune system is actually in overdrive. Other people, who are having a little fever at home, or their immune response is actually, probably a good immune response that's important for them to control the virus. So we should not use steroids in those people. And so which is why in this trial they found that people who were not hospitalized or not requiring oxygen, if they were given steroids, that made them actually worse. So this was a good lesson that those people must not receive steroids. So sometimes I get a call from my patients, oh, I have COVID, I'm at home, but my oxygenation is good. Can I take steroids? So I'll say no, because we want to maintain, let your body fight the virus. But only if you get sick that you need to come to the hospital or require oxygen, or your oxygen level goes. So that's where we want to use the steroids. And there are other medications that have come into different trials, and these were medications that are usually used for arthritis and other autoimmune diseases. And it was thought that perhaps since the immune system is in overdrive, we could try some of these drugs. So at this point, we don't have clear data if these drugs are helpful, but there are still a number of clinical trials that are happening to understand the role of these medicines. And there was a lot of hype about plasma. So plasma is where a person who has had COVID, that they have recovered, and it's been a month since their diagnosis of COVID, they could go to a blood bank, and plasma could be obtained from these individuals. And that plasma, because it has antibodies that were made by that individual to fight the virus, can then be given via the plasma to another person who is newly sick with COVID. So there have been a number of trials, and the data has not been very strong to show that there is a benefit on this. And I think at this point, we still need more data to before we make any wide recommendations about the use of plasma. And what's been exciting just this month is the FDA authorized use of monoclonal antibodies, and a set of 2 antibodies that can be used combined for people in the outpatient setting. So people who are mildly ill, but they don't require hospitalization. And so what they found was that these antibodies may reduce their risk for hospitalization. And in the group that these antibodies were tested, none of the patients died, and hospitalization rate was reduced to 70%. So what these antibodies are doing is that they're binding the virus. So the virus then is unable to bind the human cells. So this is how these antibodies work. And so who should get these antibodies? So this is not, a treatment that's easy to give, because it has to be given intravenously. So person has to come to the emergency room or a hospital to get the treatment. So this treatment is recommended only for people who may be at high risk for developing severe disease. And who is at high risk for severe disease? It's people who are older, people who are over 65 years of age, or people who are over 55, but they have heart disease, high blood pressure, COPD, asthma, or any age. So I think here what we learned is that obesity, is a very high risk factor for people, making people who are obese tend to have a severe disease course, and people with diabetes, kidney disease, or weakened immune systems. So these are the people who, so if you have, any of these conditions and you are tested positive for COVID, so even if you have a mild illness, it would be, important to consider reaching out to your physician to see if you may be eligible for these antibodies. And there are websites that you can access to find out which hospitals are offering this. So currently there are a handful of hospitals in the Seattle area that are offering these antibodies, but the goal is over the next month to make these antibodies more widely available. What about prevention and prophylaxis? So sometimes a question comes that I may hear from a patient that they say, oh, my son was visiting me, last week, and now he tested positive. What should I do? So there is really no treatment that is approved at this time to prevent infection. And what about when do you need to quarantine? So the quarantine period, is about 10 days from onset of symptoms. So if you become ill, if you develop your first symptoms today, then you need to quarantine for 10 days from today, and you can stop the quarantine at 10 days, assuming that you do not have any ongoing fevers, etc. And some people have developed no symptoms. They get tested because they had an exposure and they are positive. So in that case, again, we say 10 days from the positive test. And one thing that I strongly recommend to my patients is that if you have a mild illness, or if you have been tested, you're positive, and you don't have any symptoms, but still it's important to monitor your oxygen. The pharmacies, you can get what is called a pulse oximeter that costs maybe $15 to $20, and that's a really good tool to have at home. So you can check your oxygen levels 2 or 3 times a day, particularly if you're older or have one of the conditions that we were talking about that may pose a higher risk for complications. And this is so strongly encouraged because patients with COVID can develop what we call silent hypoxia. Silent hypoxia means that their oxygen level may become low, but they're not aware of it for some reason. They don't know. And so early on in the pandemic, we would have patients come to the emergency room. They would be really sick, and their oxygen levels would be 70% of what they needed to be, but they would be unaware, and they would need to get on a ventilator right away. So so this monitoring at home can be very helpful. What about post-COVID syndrome? And we're seeing more and more of that as we are getting further in the pandemic. So most patients with COVID, the illness is lasting like a week or 10 days, a mild illness, and then they are feeling better. But about 10%, so 1 in 10, may have what we call a more prolonged illness. They may have fatigue, they may feel a little short of breath, and they may have body aches, joint pains, so a variety of symptoms. And that can be very worrisome for a lot of patients. So, but I think it's important to understand that most patients do recover on their own. And what's needed is just more holistic support, rest, management of symptoms, their body aches. They may require some Tylenol, and then slowly kind of increasing in activity. And as I mentioned earlier, again, home pulse oximetry could be helpful in monitoring breathlessness. And if they develop more severe respiratory symptoms, cardiac symptoms, neurologic symptoms that are new, persistent, progressive, then they must reach out to their doctor, who may need them to see a specialist. Because again and again, we see that people with COVID may, because their immune system can go into overdrive, that can result in other complications where they start developing blood clots, or they may have a heart attack, or they may develop a stroke even like a week or a month after COVID. So without getting anxious, but continuing to monitor for some of these other complications. So I'm going to touch briefly upon COVID in India. And so the Ayush ministry, as I mentioned earlier, it encompasses Ayurveda, yoga, naturopathy, Unani, Siddha, and homeopathy.
Are you okay?
And early on, there were a lot of assertions made that different compounds or different drugs that were cures for COVID, and but subsequently now, fortunately, there is a task force and that works to seek scientific validation of traditional medicines. So I think this is making the whole process more scientific and data driven. It has some awesome info, some graphics, and ways to boost our immune system. And I think that these could be just very useful, particularly in patients to just maintain a healthy lifestyle, because I think good rest and nutrition is all very important to keep our immune system in good shape. Um, as we might know that if we are stressed and under a lot of strain, we're more likely to get colds and other infections. And I think the same way with COVID. Uh, so so I think some of the recommendations that I see here, keeping ourselves hydrated, consider doing some yoga, meditation, and I think, as we know, that can keep us, in a more relaxed state of body and mind, and some, other anti-inflammatory strategies, such as use of turmeric, garlic in our food, and some other measures to promote immunity that I see kind of no harms related to these. And these could particularly be helpful in patients who are recovering from COVID, dealing with the post-COVID syndrome as well. And want to share some pictures that kind of fill me with pride. So here is the launching of India, the COVID vaccination drive, which is the world's largest drive. And in good style, we see government officials praying over a box of vaccine doses in Mumbai. And as you might know, we have two vaccines that are being used in India. One is the AstraZeneca vaccine that is also being manufactured by the Serum Institute of India. And the second is, sort of a real homegrown vaccine, and that's called Covaxin. And both are being used in the vaccination drive. And India is also setting an example of vaccine metry, where they're sending vaccines to neighboring countries, and these are donations of millions of doses of vaccines. And so this is just a news brief on the NBC from earlier this week, that India appears to be set to become a vital COVID vaccine maker, perhaps second only to the US. And we have to remember that even before COVID, the country actually produced up to 60% of the world's vaccines, and at a relatively low cost. And so it's felt that the country has the capacity to produce vaccines for both its own population as well as for other developing and developed countries. And thank you very much.
Yeah, thank you so much, Dr. Malhotra. This was excellent, very helpful, and I thought the integrative medicine portion was amazing and insightful. So now I will hand it off to Junie to introduce our question and answer session. So yeah, I'll hand it off to Junie now.
Thank you. So I think now we can open it up for some questions. So we do have a list of questions already collected from the community, but we also invite the audience to ask any questions you may have. Please type them into the chat box, or please click on the button to raise your hand and we can unmute you.
Okay, yeah, thank you, Junie, for that. And again, feel free to type any questions in the chat, and along with your question, please make sure to type which one of our speakers you would like to ask this question to. So the first question that we have is for Dr. Munshi. So Dr. Munshi, what are different ways that a person can get the vaccine in King County, and when will the vaccine be, when will the COVID vaccine be opened up to the wider public?
Thank you. First of all, I want to thank the organizers to organize such a wonderful event. And again, it's very nice to have this sort of a community educational forum. And thank you, Dr. Karkhanis and Dr. Malhotra for those wonderful presentations as well. So being an internist, I just wanted to tell you how close to my heart this topic is. And I see this, I have been every single day living this clinically in person in my clinic with my patients. And I think it just has taken a different toll on everybody. And being a clinician, being there from day one, it's just been a very, very, very challenging, unprecedented, outbreak, pandemic, which has affected patients medically, economically, emotionally. And I see patients starting from age 18 up to older age group. And again, I think I can't tell how much I have seen this virus affecting my patients. Specifically, I would probably say one thing, the topic on COVID in the elderly. Just being, in internal medicine or in medicine, you try to have differential diagnosis of a disease or a presentation of a symptom clinically in a patient when you see them in clinic. And I think now if I see a patient with unexplained weakness, if unexplained falls, if unexplained confusion, believe it or not, I have to put COVID-19 in the differential and check them out. So that's how important it has changed our role, my role as a clinician, and I'm sure everybody's role as an internist to detect this. So again, I think going back to the prevention, it's as everybody knows, the COVID-19 vaccines are here and they prevent the severity of the disease. And eventually, when more people get vaccinated, hopefully the herd immunity, and Dr. Karkhanis and Dr. Malhotra might tell us more on that, but that is ultimately the goal, to get more people vaccinated so the incidence of the disease is less, and hence the less transmission of the disease in the community. But right now in King County, there are clinics which are open for vaccination. There is currently vaccine offered to the phase 1A, which is the healthcare providers, and then the phase 1B1, which is 65 years or older, and then adults who are 50 years and older, who live in a multi-generational household, who cannot live individually, independently, or have somebody who works outside the house, or adults 50 years and older who take care of their grandchild or a younger child. So these patients can go to various places in the community. One is in Virginia Mason, partnered with Amazon, which is a huge success. And Dr. Malhotra knows about that. A lot of my patients have been getting vaccinated there. UW and Harborview and Northwest Hospital has these clinics available, but they are still not accepting first dose series. They're just doing the second dose series because of the limited amount of vaccines available. Seattle University had partnership with Swedish, and there were large community clinics that are available there to get vaccines there, and a lot of my patients have been able to. But again, really, I tell my patients to Google King County COVID vaccine, and that takes them to a website which goes to Washington Face Finder. where you put all your statistics and see if you are eligible for the vaccine. And if you are eligible for the vaccine, that website takes you to different locations in the King County, because these that I mentioned are just larger community clinics, but there are other pharmacies, like some of my patients even have gotten them in Costco. I think the trick is to keep checking. Unfortunately, there is no systematic way to get into an enrollment into these. It's a very tough job right now, but I'm telling my patients just to make sure that you frequently keep checking these several locations to try and get enrolled.
Yeah, thank you so much, Dr. Munshi. So now the next question is for Dr. Karkhanis. So Dr. Karkhanis, of the different vaccines available, is there a difference in efficacy?
So the two vaccines in the US, the Pfizer and the Moderna, are very, very similar in efficacy. Pfizer 95% effective and Moderna 94.1% effective. So in real life, there really should not be any difference in efficacy between these two vaccines. The efficacy might change a little bit with the newer strains that we are seeing, but both of these are effective against the new strains that have been tested so far. It's 6 of one, half a dozen of the other. There's really not a big difference. So which is the better vaccine? The better vaccine is the one that you can get your hands on the soonest, basically. That's the better vaccine for you.
Yeah, thank you so much, Dr. Karkhanis. So now I will hand it over to Shravya.
Okay. The next question is for Dr. Malhotra. Is one vaccine better than the others in terms of side effects? I think you're muted.
Okay, so that's a great question. And I'm going to recapitulate something that we saw in Dr. Karkhanis' talk. So we have the two vaccines available, the Pfizer and Moderna, to us. And really, the overall side effects are very, very similar in the two, with the two vaccines. And so again, I think I would say whichever of the two vaccines, and that's how I would feel, whichever of the two vaccines becomes available to me, I'm good with that. And the side effects are again, mild and really tells you, if you get the side effects, it just tells you that your body is doing what it's meant to do. In a little bit of a immune drive working, and you're feeling some of those side effects. And usually, kind of there could be a little bit of redness at the injection site, little body aches, little headache, little fever, but nothing that's not easy to manage.
Okay, thank you. And the next question is for Dr. Karkhanis. It is people who are at higher risk, like autoimmune disorder or asthma, which vaccine is suggestible for them?
Again, both the vaccines in the trials, they did subgroup analysis and there was no big difference. So across age and gender and other comorbid conditions and races, the two vaccines are very similar. So there is not a reason to choose a vaccine because of any chronic health condition. Really, they're very similar. They're both very good. So whichever one is available to you, whichever one you can get, is the best vaccine.
And I just want to add here, it could be that very soon we have a couple other vaccines, that come into, get approved in the US. And again, I would add, that they may be actually a bit different from the ones, the Pfizer and Moderna. But again, as we heard from Dr. Karkhanis, the vaccine that's the best is the vaccine that's available to you. So I would not hesitate, to get that vaccine.
And I would like to add the side effect incidence is less in elderly population, the 65 and over. And all my patients who live in assisted living who have received it, 97-year-old, one of my patients, she didn't even feel it. There was
Yeah,
really no side effects at all for her,
yeah.
for both the shots. So it's really, really safe.
All right, I have a question for Dr. Munshi. After like we get vaccinated, do we still have to wear masks? Like what precautions can we like not take, or which ones do we still have to actively take?
So yes, masking is still really, really the best way to still prevent the transmission of the virus. And masking is absolutely still recommended, highly recommended, this in spite of getting the vaccine. The other precautions are hand washing, frequent hand washing, and social distancing. And I think these measures show that there is relatively less spread in the highly infected, high likelihood of a disease place like hospitals, where the colleagues and the people and they just follow strictly these kind of precautions to the to the maximum extent as they could. So relatively less spread because they follow all these precautions. And yes, masking is still recommended even after getting vaccine.
Yeah,
Thank
so
you for answering that
I'll,
question.
I'll just add here that making another point here is, a lot of the trials that were done at the point, they were really looking for um, illness, prevention of illness, prevention of death. So they were not really doing the nasal swabs to see, oh, are we preventing asymptomatic infections? Are we preventing? So that data is still, lacking, and more of the data is now coming. So we don't know. We think that we're reducing asymptomatic infections with the vaccine, but we're not really preventing asymptomatic infections. So that's why, yeah, we want to, because people around us, vaccination rates are still very low in our cities. So we want to protect everyone.
Thank you. And I also see that one of our participants, Leela, has her hand raised. So would you like to ask your question, Leela, to the doctors?
Yes, thanks, Harikat. I have a question to the doctors. Actually, in India today, some of my friends who are living here and parents are staying there, they were planning to bring them here and get them vaccinated rather than getting in India. So how safe it is, making them travel here without getting vaccinated and getting the dosage here rather than India? And when compared to Indian vaccines, is it the same kind of similar way that works that are Pfizer or any other vaccines here?
I'll take the question if that's okay. So in India right now, they have the AstraZeneca vaccine, the Covishield vaccine that's being manufactured in Pune at the Serum Institute, but it's originally developed by AstraZeneca and Oxford University. And that is not an mRNA vaccine. It's a DNA vector. It's a vector vaccine. They're using a chimpanzee common cold virus that cannot infect human beings as a vector. And they've put the spike protein gene information in the virus, and then that is going to go in, the DNA will get converted to mRNA. And then from that step onwards, it's the same process, mRNA to spike protein, and then spike protein induces immune response. So, sorry, slightly different vaccine. AstraZeneca did their trials a little differently. So they came out with an efficacy rate of about 60 to 70%, as opposed to these mRNA vaccines that show 94, 95% efficacy. But overall, keep in mind, our flu vaccine is only about 50% efficacious, and we still take it every year. It still helps us a lot. So 60 to 70% effective is also a very, very good vaccine. The other vaccine that's expected to be available in India is the Bharat Biotech Covaxin, developed originally in India. That will be inactivated virus vaccine. So they're going to take actual coronavirus, inactivate it with a chemical, beta-propiolactone, and then inject people. Their phase 3 data is not yet available in the public domain. So their exact efficacy data is not yet available. Will it work? It probably will. Inactivated vaccines have always worked throughout the history of vaccine technology, but exactly how well we don't know. So the question of whether people should travel here specifically for the vaccine, I think there are a couple of things to consider. If a vaccine dose is available to people in India, if it is their turn in India, they should probably just take the vaccine dose there, because the vaccine, the AstraZeneca vaccine in India is pretty effective as well. So they should just take the dose there, because what you mentioned is true. When you travel, you are taking the risk. You're going to be in contact with 100 people on the plane and at the airports, and you may catch COVID coming here, and that defeats the whole purpose of prevention with the vaccine. Secondly, logistically, how easy is it going to be for visitors to get the vaccine? This is differing from state to state. It's differing from vaccination site to vaccination site. Some are being very particular. They won't allow people that are not residents in that particular city, that don't have an address there, to get the vaccine. Some are okay with anybody coming in, so visiting parents are able to get the vaccine. So all of these logistical aspects need to be considered. There has been an outlash against vaccine tourism, because unfortunately, there were travel agencies advertising tours to the US with a vaccine thrown in. So that's not the kind of publicity you want for vaccination efforts. So there may be a backlash against what people are calling vaccine tourism. You cannot just travel to a place where vaccine is available, get it, and then fly back. So these are logistical issues. Now, if a trip was already planned and they were not able to get the vaccine in India, and there was a trip already planned for various reasons, and visitors came here and they were able to get a vaccine here, sure, go ahead, get it. But to plan a trip just around the idea of getting them an mRNA vaccine, I don't think it is a good idea, because the vaccines available in India are also pretty good. So lots of logistical issues. If they come here and they fall sick, will they have health insurance? Will they be able to get the vaccine if their second dose gets pushed ahead because of availability issues? Or like we had in Texas this week, everybody's vaccine dose for this week is essentially pushed ahead because everything is closed. Then will they push their departure date ahead and things like that? So it's a dicey situation to travel just for vaccine. If they come here and a vaccine is available and they take it, there is absolutely no problem.
So I'll add a couple more points here, and I want to clearly second Dr. Karkhanis' recommendation that I don't think it's a good idea to travel to get a vaccine here, because the risk of getting the infection from the travel is, I think, extremely high. And a couple other points: the rates of COVID in India right now are actually very low. Very low compared to what's happening in the US. So they're going to be moving from India, where the rates are extremely low right now, to the US, where the rates are, quite high, among the highest in the, world right now. And the second part, so India, does have the two vaccines, both have that we just heard about, by the Serum Institute and the Covaxin. Both are being used right now. And I think one thing that's been a little controversial here has been that the AstraZeneca vaccine, which is being manufactured by Serum Institute, we do have data on it. But the Covaxin, which is the kind of the native vaccine, so it did sort of go into implementation a little bit prematurely, resulting in some controversy that the phase 3 data are still not available and won't be available till March. But it's being used, without that efficacy data. But I do think that it's going to be, efficacious. It's, virus that's been inactivated, likely have, similar efficacy numbers there. And right now, actually, the vaccine in India is quite easily available. So it should be very easy for them to get a vaccine. There was the huge rush that occurred, around January 16th. So what I'm learning is that over the last week, actually, and some of it is because the rates, the COVID rates are so low in India, a lot of people are not going for the vaccination. So there is actually a lot of vaccine available. So I would, strongly encourage, to go ahead and get vaccinated. Just over the last week, I've had people, traveling from, Senegal, and they get on the plane, they are tested, they're negative, and they get here a couple of days later, they're really sick. So I think the risk for international travel and all the exposures is risk for getting the infection is pretty high.
Thank you for being clear about those questions.
Can I ask one question here that is directed to me about the AstraZeneca Covishield in India? Is it effective against the second strain or the newer strain of coronavirus? I don't know the answer to this. I did attend the grand rounds at University of Washington, and they talked about trials regards to the Pfizer and the Moderna. I believe there is some data, but I might defer this question to Dr. Malhotra and Dr. Karkhanis. The question is Covishield in India effective against the new mutant strain of coronavirus?
As I understand, the efficacy may be just slightly less, but not, any significantly less. I think, the main was the vaccine that was being tested, in South Africa. I'm trying to recall, which one that was. Was it the Novax, where they found that there was a difference in efficacy, in the tests in South Africa versus, and mostly related to the variant that was circulating in South Africa. So that's the only one where I've heard that there is, some reduction or significant reduction in efficacy. But other than that, and I suspect, I'm trying not to get consumed by the all of the news around the variants. I think we're going to keep seeing that because these are RNA viruses, they're mutating, and now there is this bigger push to keep doing more sequencing. So I think we're going to hear about that. And I think that, the vaccines, as we know, that the mRNA vaccines can be easily adapted. And I expect that we are going to need boosters, just sort of like with the influenza vaccine, we need a booster, every year. So I expect that we're dealing with something like that here, where we just try to keep up and let our healthcare professionals kind of keep up with the vaccine design and offer us what's most current and the best match for what's circulating. And hopefully, I think the idea is we get the herd immunity, which is like getting 70% of the people vaccinated, or or having some immunity through their infections, and so we can reduce those transmissions. And I think we're going to see lesser emergence of variants.
Thank you, Dr. Malhotra.
Thank you for answering our questions. We also have another participant, Saurav. His hand is raised. So, Saurav, would you like to unmute yourself and answer ask what question you have?
My question is really quick. Thank you again for all the sessions. It's very informative. How long these vaccines are effective? Are they valid for lifelong or 1 year, 6 months? Please speak about that.
I can take that question. So we don't know for sure. The short answer is we don't know for sure, because these vaccines have been out for less than a year. We know that they last several months. They've been out for several months now. And data seems to suggest that they are probably going to be good for years, but we need data to prove it. So we kind of have to watch our infection rates. We have to watch what happens with mutations and variants, and what boosters we may need, and how many people agree to get vaccinated. And that's how we will know. Again, keep in mind, how good a vaccine is depends on how many people get it. If very few people agree to get it in a community, then even a 95% effective vaccine is not going to help. So everybody needs to agree to get the vaccine when it's their turn, because, you know, they say the way to get something done is to take the first step. So you can't wait for the final design to be ready before you take the first step. You have to start with the first step when the first step is available to you. And for most of us, this vaccine is our first step to fight this pandemic. So we take the vaccine, we think it's probably going to last a long time, because as immunologists, we know vaccines last a long time, but viruses are unpredictable. So we have to keep that in mind and just study it as the data comes along.
Thank you.
Thank you for answering that question. We also have another participant. Their name is Galaxy Note 10, and they have their hand up. So if you would like to unmute yourself and ask your question.
Yeah, thanks, Harkirat. My name is not Galaxy. I think that the phone name is coming. So my name is Tajinder. So I have two questions. One is like, is it possible to check that if I have immunity already? Because I can, like a family in India, like the area in India from where I'm, like the 90% almost people got the COVID and they were fine. They had very mild symptom, and like, is it possible that if anyone have immunity, he doesn't need the vaccination, or he doesn't, like, I'm not going for any of the flu vaccine ever before. So is there any possibility to check and then to have a vaccination or not? Can that decision can be taken, or it is preferred to take it for each and every one?
Yeah, I can take this question. I think it's a very good question. It's something that comes up quite a bit. So what I would say is that we don't know how long, any immunity from infection lasts for. And likely that the immunity that we get from an infection, is different from the immunity that we get from a vaccine. And so far what we know is that immunity from an infection, maybe lasts for about 3 months or so. It could be longer, but that's what we know at this point, that it likely lasts for 3 months or so. So, and second, the antibody tests are not, terribly accurate. So there are some tests that are more accurate than others, but there are, issues around, false positives, false negatives. So the information that we get from the antibody test is not, extremely reliable. And, third, as we know, the viruses are changing. So I think given all of this information, I would, recommend just, getting the vaccine.
Okay. Yep. Thanks. I have a second question. In the same house, I have my wife. She's asthmatic, and my son, he's also asthmatic. But they are not 50 years old. So, is that any criteria? Maybe the question for Dr. Munshi, is that the criteria makes them to get vaccinated early or not? And like both had the like wife, she had the severe bronchitis I think couple of times.
So unfortunately, currently they are very strict with the criterias. Correct me if I'm wrong, Dr. Malhotra, Dr. Karkhanis, the phases that they have are very specific to the 50 or over with living with somebody, multi-generational household, or being dependent on somebody who works outside the house. So they are not talking about younger than 50 who have high risk, unfortunately.
Yeah, I agree.
Yeah.
Okay.
I would just like to add that this again varies state to state. So since I'm in Texas, the criteria here are a little different. So probably best check your local criteria. So here right now in Texas, phase 1B includes everybody age 18 and above with a chronic health condition. So anybody age 18 and above with obesity or COPD, chronic bronchitis, asthma, hypertension, coronary artery disease, pregnancy, immunocompromised, cancer. Right now they qualify for phase 1B, which is what's going on in Texas. So it differs from state to state. Each state has been given the capacity to kind of make their own judgment decisions about the criteria.
Okay, yeah, thanks a lot. I really appreciate you all, doctors and Mehers and Dr. Anita, putting this info session. It's very much informative. Thanks a lot. Yeah, thanks, Harkirat, Meher.
Yeah.
Thank you for asking your questions. I just wanted to give a brief overview that if you were like, since a lot of the questions are coming out, where to get vaccinations, how to get them. So some resources are that you could, like, if you go to a healthcare provider, maybe possibly they can give you the vaccine. And if not, there's also, like mentioned by one of the doctors, there's a phase finder website that you can go to. I'll attach it to the chat right now, where you fill out a form and tells you if you qualify, if those are the stages you can qualify at, and then you can see where appointments are available. Another resource is for Kaiser Permanente vaccines. We have had one of our members reach out, and she has like, I'll attach her number into this chat as well. And her name is Sutinder Chavla. You can just like give her a call and give your date of birth, your age, and see if you qualify for the Kaiser Permanente vaccinations. And I will link her email in the chat as well. And another resource, as mentioned by one of the doctors, was with Virginia Mason and Amazon. And right now we're like compiling a spreadsheet where you can be added to the waitlist for that vaccination waitlist. And I can link you to the email that you can enter your information to, that where we can record it and add you onto that waitlist. And this is the Worth a Shot 07 email. All right, and then now we can just continue on with questions again. And Sharavaya, you can ask questions.
Yeah, and I saw that Simmer had her hand up. Would you like to ask a question?
When will children get the vaccine?
So currently trials are going on for children aged 11 or 12 to about 16 or 18. So Pfizer and Moderna expect those trials to be done and the data to be out by summer. And then they are already recruiting for trials for ages 6 and above, so 6 to 11 or 6 to 12, but that will probably take a little longer because it's harder to find children willing to volunteer. It's harder to find people willing to volunteer their children for these trials. So that might not be out late fall or later this year even. And so far, I don't think any of the vaccine manufacturers are going to do trials for less than age 6. So that is probably not in the near future at all. We can probably look forward to adolescents. So age 11 or 12 and above, data should be out by the summer.
Okay, thank you for the answer, Dr. Karkhanis. I saw that Ajuni also has a question. Would you like to mute?
Yes, so I have a question for Dr. Karkhanis. So for older patients who have had heart failure in the past, is the vaccine as effective for them, and is it safe to take?
Yes, so people who have had coronary problems, heart failure, other chronic health problems, the vaccine is effective. None of these health problems seem to affect the efficacy of the vaccines, and it is safe for them to take. Now you have to take precautions. If you have a chronic health condition, you have to make sure that you stay on your medications on the day of the vaccine. Don't hold any medications. Make sure you're not dehydrated, because even minor side effects can get more troublesome if you are even mildly dehydrated. Keep all your medications on hand. If we are talking about somebody that has chronic health conditions that is very elderly, then we have to pay attention and make sure that they eat and drink properly. And they even mild tiredness sometimes in our elderly family members, they may not eat or drink for a day or two, and then all the side effects become worse for them. So yes, the vaccine is absolutely safe for people with heart failure history. They should take it because they will probably not do well if they catch the coronavirus infection. The vaccine is way better for them.
So I think let's begin to wrap up for time reasons. So I see, let's take one more question. I see Arushi has her hand up. So let's take that question and then we can start wrapping up.
Hi, thank you. I have a question of what makes the vaccine mainly like restricted to adults of older ages? And is that because some of the components in the vaccine are harmful to children of younger ages?
No, it's just restricted to people of older ages because that's what was studied in the trials. So in science, even if you think something is safe, unless you prove it's safe, you can't claim it's safe. So since we haven't proven that the vaccine is safe for people younger than 16, we can't give it to people younger than 16 yet. But there's nothing in these vaccines that would make one think that it's harmful. And that's why the trials for 11, 12 onwards are already going on at this time. And we will probably prove that it's safe and effective, and then we will give it to children. The vaccines really don't have any ingredients that would be harmful for anybody except for the very few rare people that are allergic to those ingredients. Otherwise, the vaccines are very safe overall.
Okay, thank you.
Yeah, thank you so much to everyone. So now I think let's start wrapping up. And Herkira, I know you talked about how to make an appointment. So so now I'll hand it over to Shravya. Shravya, can you talk a little bit about the resources that we have at Worth a Shot for the community?
Sure. So we have a number of resources for the community. There's also printed, and in the Worth a Shot website, if you go to the Youth Aware magazine link, you see that there, and if you press on the Worth a Shot, you see that there are also webinars we have recorded with websites. So you can check that out, and you can even check out the entire website. And we also have different languages. I think Meher mentioned this before in the beginning, but yeah, we have different languages translated if you want to read it in a different language too.
Thank you for that, Shravya. So now I'll hand it over to Ajuni on our vaccine pledge.
So we would like to share that we are collecting community pledges on the Worth a Shot page. If you would like to send in your video recording with pledges for why you want to get the vaccine, please email them to us at worthashot07@gmail.com.
Okay, so thank you so much to everyone for joining us today. And I also wanted to mention that we have Diane from Yakult here today. We really want to thank her and Yakult for supporting so many of Youth Aware's community initiatives. So thank you so much for that. And thank you so much, Dr. Karkhanis, Dr. Munshi, Dr. Malhotra. We're so grateful for your time, expertise, and patience. And we really appreciate that you took time out of your busy schedule. And I know that this has been very impactful for our community. And like Dr. Karkhanis, I know you're in Texas, and I know there's a time difference, and we really appreciate that. We're really honored to have you here today. So just thank you so much to everyone.
Well, thank you, Meher, and congratulations to Worth a Shot team. I'm just very, very inspired to see what you young women are doing. So that's incredible. I'm happy to be part of the endeavor.
Thank you so much, Dr. Malhotra.
Same here. Congratulations to the whole team and thank you for the opportunity, Mayor. It was very nice to connect with Dr. Malhotra and Dr. Munshi and all of our viewers today.
Yeah, likewise. It was very nice. I think I learned a lot.
Yes, yeah.
Thank you so much. I agree. It was a very informational session for me. And again, really proud of the young organizers and
Exactly.
very, very inspirational for all of us. So thanks for doing that and good luck to all of you. And very nice to meet you, Dr. Karkhanis and Dr. Malhotra.
Yeah,
We're close
likewise.
to each other, Dr. Malhotra. We should meet someday.
Yeah, absolutely. Absolutely.
Thank you very much. It's such an honor to see all of you wonderful women here. And I'm so grateful to every one of you. I'm so grateful to Lukena, to Uma, and to Prachi. I have had the honor of talking to each one of you separately. And I hope that we can meet one day. Thank you very, very much. I'm so grateful from the bottom of my heart that you did this for our community. Thank you.
Thank you, Dr. Chopra. Thanks a lot.
Bye-bye. Bye-bye.
Bye.